So it is my pleasure to invite Dr. Angus Turner, Associate Professor Angus Turner, who is a good friend and has been involved in the Indigenous eye health space for years. He's the head of Outback Vision, or the director of Outback Vision, and this presentation will highlight the innovation, collaboration and coordination of services in remote and First Nation communities across Western Australia. If we can please join me in inviting Angus.
Thank you kindly, Kaiba. It's a great pleasure to be here, even in the after-lunch slot. And I'd like to start by acknowledging the traditional owners of the land here, the Whadjuk Noongar people, and pay my respects to their elders, past and present. And we're so fortunate to be here in Fremantle, and with that river, the Derbil Yerrigan, coming right out here. And we're very privileged to work among the many peoples across this great state. So today I'm just going to give you a little bit of a snapshot, as much as 20 minutes or less can do, to talk about how we need to work together and essentially to help get a job done for anyone living in a regional area, and even in the urban locations of Perth. There are people who struggle to access healthcare systems. So I've already gone ahead of myself, but I'll stay right there. There's a big state, you know that. For those who are from other parts of the country or elsewhere, welcome to WA. It is a big one, and we're kind of proud of it because there's one person per square kilometre, so there's plenty of room. But there's just, most of them live around here. So wherever you live elsewhere, it's quite hard to get in and out of places. And those kind of places, the healthcare needs are great, just like anywhere, but sometimes even more so, given there's less access to the prevention of various health conditions. It's a great privilege to be able to work in that space, and this is just a little roadmap of some ophthalmology specialist provision from Outback Vision. And of course, I'm really looking forward to the next session, which is on the optometry map, because that's way more impressive. It goes far and further than any of these spots are to see primary eye care delivered across the state. So looking forward to hearing that. But making sure that the optometry and ophthalmology work together to not duplicate and waste effort, but rather to work where we're needed, is one of the key ways to deliver our eye care so that the patients get an efficient pathway that actually makes sense for their need. So they're not in the wrong spot at the wrong time. So that's what we've been working on together for ages, and way back some sort of research showing that if you work together, you see more people quicker and it costs less. So on the premise that there is evidence behind stuff, we just do it practically. And the optometrists, some of you might recognise there, Margie, she's been doing it for a while up in Kununurra, and has brought together a lot of the teams. And it's great to see some old friends here today who've been around for a long part of the journey. Stephen Copeland's up there, still based in Broome. Margie's been in Kununurra this year, but is currently wandering in various other parts of the state helping with eye care as well. And telehealth connected us together in 2015, a few years after the GPs had access to specialists through video. In Australia, the optometrists were brought into that picture of telehealth being an efficient way to do things in 2015. And in Australia, we did choose a strange kind of model, which was you have to actually have a video chat to each other. Sometimes that's actually really hard to make happen on the spot, because you need to have the optometrist with the patient available, having just seen them, while many people are waiting out the door, as well as the ophthalmologist stopping what they're doing to do that video chat. And that rhythm has proved actually quite difficult to achieve for most of Australia, and it's only once you get enough kind of rhythm and volume that you can actually provide full-time on-call telehealth. So Outback Vision now, it's pretty much taken 10 years, has got enough resource of people helping to be able to pretty much guarantee that someone will be there to talk to the patient. Telehealth became the buzzword in COVID, of course, and at that point, lots of regulations got scrapped. So one regulation was you have to have a video connecting, and as you know, the internet, some places the video is going to destroy your chat. So Also with patients with vision impairment, sometimes what's the point? You just need a nice telephone landline to talk to that patient and they'll understand a bit better. So COVID kind of helped that stuff just happen without arguing too much. It's now telephone as well. And in addition, some of the barriers that people were worried about were, what platform do you use to do this? You need expensive infrastructure to get telehealth going, and you just don't. So the Canberra sort of people thinking about this back in 2011 said, it doesn't matter what you use. You can use Skype, WhatsApp, FaceTime, doesn't matter. But then we all decided to make it more complicated, and our state governments decided you couldn't use any of those things. You had to use proprietary telehealth software that had been designed for the purpose, which meant that it had lots of bugs and didn't evolve very fast. Whereas it took until COVID for America to scrap all those barriers as well. And so now you can use the thing that you use in your pocket with that kind of video is the one that works most of the time. So this is another windy picture to just symbolise that we are connected in many ways, from the general healthcare services provided by the Aboriginal health workers, the GPs, the diabetic educators, all right in the middle of the patient's journey that they've got with health, and then through telehealth links, but also through our own referral pathways. We have the optometry and ophthalmology that quite often in the remote areas is going to visit for a short number of days. So if your short number of days are well coordinated, which requires great relationships with the people who are there all the time on the ground, and those short number of days get people who need glasses and a general health check to the optometrist, and then the optometrist can get the right crew that needs some surgery or some treatment to the ophthalmologist. And then our day or two in town really helps the most people. So one of the other parts of the project to work together has been getting the right equipment out to the bush, and this vision van has been going now for 8 years, believe it or not. And some of the crew on the van are here off roster, the rest are out on the road and working today. But that van is still opening and closing and mostly functioning, although Christine Stott, our manager, will pull a face because she has to do a lot of work behind the scenes to keep the wheels turning, and it's hard work. So don't start a mobile truck unless you really have thought it through. But it provided many services over the last few years, and it's about 3,000 patients a year get their specialist needs in 22 communities. And that's really worth it because those 3,000 patients would have had a long way to go to get their laser or their other specialist equipment that's a bit too expensive for every hospital to own. So here's some examples where Aboriginal health worker up in Derby is connected in on the OCT that can be viewed remotely, and the vision van on the side there as well. All of the imaging that is collected is just come in leaps and bounds because you don't get a grainy photo texted to you anymore. You get the full picture of the OCT slice by slice. And so you can just scroll through it as though the patient's sitting next to you. And that's what's extraordinary about ophthalmology is most of what we're doing is actually based on what you see, the picture of the back of the eye or the front of the eye, and those pictures are now much more easily transmitted. So we can see the slices and make a good treatment decision, chat to the patient by video if required, and then organise the care that that patient needs and save a couple of visits. So this all led us to visiting the Kimberley a lot, and if anyone's driven out to Kununurra or Wyndham with a caravan on the back, it's a long way, and by the time you get back down to Esperance, you're kind of a little bit late for your next appointment. So the regional hub came together thanks to a lot of supporters, some in this room, and it's been a good project because now we can work permanently in one spot and fly from there. So optometry is now got a permanent base, which has been fantastic specifically for the training of new workforce, thanks to the UWA crew who have set up the school to train optometrists in this state. Has been a brilliant initiative, and we're now going to have more opportunities to actually educate and train together, because when I did med school or ophthalmology there were no optometrists around, but in our training centre there's registrars training, next to Aboriginal health worker training or optometry training. And the rural clinical school for the medical students is also there. So the medical students actually have a base in the same eye hub, and they're there for the whole year. And ophthalmology is one of their exams that I get to set. So they're all good friends of mine now and sort of listen to every word I teach for that little exam moment. But it was a journey. This was our first office, and Kerry's there cleaning amazingly and was involved in the first year. And she helped us build all the equipment as well. And everything arrived in a box just when COVID shut WA out from the world and technicians could not come to put things together. And we got it all working and used some old equipment as well. And got things out of boxes and got new surgery happening. So there's amazing tertiary facilities in the northwest. And when it comes to retina surgery, that's been one of the exciting bits for a specialist, is that trauma, diabetes, really complicated eye operations that I don't know how to do. I have colleagues who are able to do them in Broome, and they live there. And so when someone's got a trauma or an eye that would have needed work in Perth, to get someone to commit to Perth for a month sometimes, because it's got to have a gas bubble in the eye and you can't fly home and you need lots of follow-up, all of those things meant that half the patients that would have benefited from retina surgery just didn't happen. And so we've studied that recently and done an audit to show that we're just doing way more retinal surgery that has come out of the woodwork, if you like. People just didn't get it done before, and that would lead to blindness normally. So that's really nice to know that those patients can get seen close. So amazing equipment thanks to generous philanthropists, and we fly every week somewhere, just about every second week. There's off to Fitzroy, Derby, and then Halls Creek, Kununurra, then Karratha Headland, working with Byron there, you guys at the Werricka Eye Health Service. So it's really great to be able to turn up to these places for one day and get so much done, because everyone else on the ground has been working together to make sure that the work in the hospital is very triaged. It's the right stuff to be fixed. Sometimes you fly to Karratha and you can't land. That was a red dust storm. That was right on top of the airport, so the pilot got nervous and circled for a while, and then that big red cloud disappeared and we landed 10 minutes later, but it was moving fast. And then the hub itself has all these other things to think about. Speaking with Diabetes WA, that you've got to think about the prevention starting way back at school in terms of healthy eating. We've got a community garden, got a food kiosk that can engage with the teaching of the kids. There's a high school student doing work experience there next week. And the one little patient there is 7-year-old whose twin brother put a screwdriver in his eye, and he got fixed up from Fitzroy in Broome with an outcome that is going to be really good. Whereas that kind of delay of that type of injury, waiting to get to Perth, actually has a difference between seeing and not seeing. So lots of kids come and do their school lesson on how to make food and enjoy the process. And we'll be touching on it in the afternoon, another little session on the research side of things, but this is going on at the moment in the Pilbara, trying to get the screening done closer to home as well, with people who haven't had eye training. So that's the next group we can work with. Not optometry, not health workers, but someone who can use a camera that's automatic and have the AI assistance to tell you if there's a problem or not in the eye. So we've got a lovely team and really happy patients that are the main reward and reason we do this work, and lots of sponsors behind it to make it happen. But in particular, I'd like to welcome in our optometry colleagues who go far and wide. Thanks for listening to me today.